Good morning. Thank you. I'm going to fail miserably on the time. I'm certain I typically do. Unfortunately, I'm neither a physician nor a cultural anthropologist, but I do have a little experience as the token physician on the panel. My wife was not a nurse, but she went initially into political training, political science as an undergrad, and then switched to early childhood education, which I'm not sure there was a real change. But what she did learn were the skills necessary to manage physicians, which is what nurses, unfortunately, have been doing for decades. And that's, I think, where the cultural change needs to begin. They need to not be managing physicians. They need to be managing data. As healthcare undergoes this change from a physician-centric, idiosyncratic methodology to delivering care one patient at a time, we need to move to a much more ability to obviously focus on one patient at a time, but deliver the best care for every patient every time. And to do that, we need a number of things, right? In order to reliably deliver measurably better care, we need to do things like measure the quality of care that's delivered, and we've made tremendous advances over the last several decades. We need to have folks that are steeped in a culture of data, that can understand that data, that are steeped in the culture of feedback and translation of data. When I work with leading health systems like Geisinger or Mayo or Cleveland Clinic, their secret sauce in many situations is developing intermediate clinician leaders, doctors and nurses, that have the ability to take that data, transform it into something that the average physician or nurse on the front lines caring for patients can understand, and then most importantly, know what's necessary in that work unit to get a measurably better result. And what we've seen over the last decade is nurses coming out of the bedside practice, and I agree that when we do our training in hospitals and other academic settings, that we're not training the full panoply of skills that we need, but coming out of bedside nursing and going into quality and going into innovation and going into administrative leadership positions, but carrying that legacy of great patient care, tremendous attention to details, which is a skill that many physicians lack, by the way, and taking it into their new roles in a way that's very different, and stepping out and being seen as the leader of the team that creates measurably better health. And they do it in, like I said, in quality and safety and innovation. And in the ambulatory setting, the roles are expanding dramatically. And I think, one area that nurses have done well in, but may not have the sufficient tools and training, is in that team leadership role. In many of the innovations that I've been part of, the nurse is often the translator for the physicians, who still tend to be off by themselves in the corner often, and she or he is running, the nurse is running the rest of the team. So collaborating with the pharmacy folks, collaborating with the, with Jeff Brenner's hot spotting, undergrads and med students. Jeff's a great friend of mine. The ability to manage that team is not a typical skill that's taught in nursing, and not something you necessarily pick up at the bedside. The ability to manage a population of patients as opposed to just one. When we were looking for our commando RNs for our medical home deployments, a lot of folks said, oh, you want to go to the ICUs. They're the brightest and the hardest working, and there's a lot to be said for that. And they're used to focusing on one patient at a time. And now they're going to be responsible for a population of hundreds or thousands of patients. A lot of them couldn't make that transition. So teaching that skill set of understanding, yes, you have to deliver great patient care one patient at a time, but you have to be aware of which patients need that care and how you do it. That's a different skill set. And I think, we talk about barriers and things that we need to overcome. I think the training and the skills, and then quite honestly, the support tools. When we look to EHRs for medical records, everyone expected magic a decade ago when we deployed them, and guess what? They sit there like a lump of coal. We've spent a decade re-engineering them so that they're now an active member of the team, which is great, but they don't address most of those auxiliary nursing skill needs. So they may help with some of the direct patient care needs that nurses have, and we're good at prompting nurses, because although they're better at detail than physicians, they're not perfect. we haven't addressed, and we're just now beginning to understand the technology needs that would link medical homes with their communities, with their pharmacies, with the nursing homes, right? So building that infrastructure and making it as easy as possible for the nurses to do their jobs and to share information in a way that's meaningful and reduce that endless documentation of skills. When I was a residency director, I used to say there's nothing more dangerous than a nurse with a clipboard, right? Because they were usually from quality or some review session. Now I think there's nothing more dangerous than a nurse with a clipboard, because that means she's really inefficient. She's not getting the support or help that she needs to do her or his job well. And so I think, you know, we need to think about the training and support, the new skill set they have. We need to think about the deployment of technology to support these new advanced nursing positions. And then at some point we're going to need to solve that issue of how the physicians fully integrate with the rest of the team, or the physicians will be left off the boat. Thank you.
Thank you. Well done. Everybody is performing admirably. Diana,